Hello and welcome everyone to tonight's webinar on the art and science of deprescribing psychotropic medicine. I am Dr. Leonie Harcourt, a GP advisor at the Capital Health Network. Also with me is Kanal Mohiti, the events lead at Capital Health Network. And of course, we are very lucky to have our presenter, Dr. Mark Horowitz, who has been at the vanguard of this topic. Now, I should all let you know that this is not Mark's first rodeo. He's actually presented on this topic to doctors over 600 times. So he's an expert on the area, and we're very lucky to have him tonight. So first, we'd like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. And just a flag for Health Pathways. Health Pathways has pages is a free resource for primary care practitioners, and it has management guidelines and referral pathways for many mental health conditions, and also a shout out for the Healthcare Consumers Association website, which has patient resources on antidepressant deprescribing under their antidepressants in older people webpage. So they're resources that GPs may be able to hand out to their patients after this webinar. So all participants have been muted. Please address any question and answers you have in the Q&A box on the Zoom window, not the chat box. So we always get questions in the chat box, but we would really prefer them in the Q&A box. And we'll have a Q&A session after Mark's finished his presentation. So lots of curly questions for Mark, please. So now over to Dr. Mark Horowitz. Mark is a clinical research fellow in psychiatry in the National Health Services in England, a visiting lecturer in psychopharmacology at the King's College London, and a trainee psychiatrist. He also has a PhD from the Institute of Psychiatry at King's College London in the neurobiology of depression and antidepressant action. He is the lead author of the Maudsley Deprescribing Guidelines, which has received a lot of press recently, and the guidelines provides the basis for the national guidance in the UK from the NHS prescribers on how to safely stop psychiatric drugs, and has been endorsed by the Royal Australian College of General Practitioners in Australia and the Royal Pharmaceutical Society in the UK. He's also co-authored the recent Royal College of Psychiatrists guidance on stopping antidepressants, and his work informed the recent National Institute of Clinical Excellence guidelines, so NICE guidelines on safe tapering of psychiatric medications, including antidepressants and benzodiazepines and Z-drugs. So over to you, Mark, and thank you very much. Mark, you're on mute.
That's what you say. You say someone's done it hundreds of times and they don't know where the mute button is. Thank you, Leonie, for inviting me, and thank you for the introduction. Actually, wouldn't mind you sending me those resources you've just mentioned. I haven't come across them before. I'm not sure if they're consistent with what I'm saying here this evening, so I'd be interested to see them. I'm going to start by sharing my screen. I'm going to play a video that was made by some patients in Australia talking about their experience of coming off antidepressants, just to give a bit of a flavor before I start showing you graphs and slides about neurons. So I'm just going to start, and please tell me if you can hear this.
Why were you first prescribed an antidepressant?
I was prescribed when I was 22, and I had just had a relationship breakup.
I was prescribed an antidepressant in 2013 for a chronic pain condition called trigeminal neuralgia.
I was first prescribed an antidepressant because I was going through some dark times in life. I had an ACL reconstruction on my left knee, and I was going through school at that time.
How did the antidepressant make you feel?
I felt like I was just like a robot. I was
very emotionally numb. I still had the anxiety, but it was numbed down. But unfortunately, not only did it numb down my anxiety, it numbed down my emotions. You know, I couldn't feel any intense happiness or sadness anymore. I lost the ability to cry.
I put on a lot of weight. I completely lost my libido. And I just found myself incredibly tired.
When I was first put on these drugs, I thought it was fantastic because it quieted my mind and numbed me, but I didn't know that the trap I was digging for myself.
What has your experience been when you came off or reduced the dose of the antidepressant?
My brain felt like it was burning and splitting, but everywhere, along with pains and whooshing feelings I can't describe. I was forcing myself to eat. I lost around 14 kilos. My clothes became really baggy. I had diarrhea I couldn't stop. I was super sensitive to light and sound, even hot and cold.
All hell broke loose. I have never experienced the terror, the extreme physical and mental upheaval that I went through. I experienced my first major depressive episode like nothing I'd ever experienced before in my life, but I just thought it was me. It was much worse than any low mood I had previously felt during my first 27 years and before being prescribed an antidepressant.
I became sensitive to noise. I was fearful of people visiting. I couldn't watch the television. I couldn't read a book.
And I experienced akathisia for the first time ever, which is actually quite difficult to even describe, but it feels like an extreme panic attack combined with just explosive feelings of pressure in your brain and your entire body.
I had intense anxiety, intrusive, dark, looping thoughts. I developed akathisia and paced around the house so uncomfortable in my own body. I wanted to rip my skin off.
Dizziness and also these sort of zappy electric kind of sensations that I've heard called brain zaps. They didn't worry me so much as the emotional, psychological tsunami that then hit me.
Inability to function, struggling to walk in a straight line. That doesn't, I could go on and on. Yeah, just struggling to stay alive.
How has antidepressant withdrawal impacted your life as a whole?
It has pretty much destroyed my life. It's traumatized myself and my family and caused extreme distress.
And one of really the worst thing that's been for us is the isolation in regard to medical professionals. They just do not understand the severity of withdrawal symptoms. It was just terrible visiting doctors and realising they had absolutely no idea about this experience.
Friendships have been affected. People just can't comprehend how a prescribed medication can cause so much harm. I've lost years of employment as a direct result of antidepressant withdrawal.
It's hard to think of an area of life that it hasn't impacted. Obviously, had a massive impact on my family, a massive impact on my sense of well-being. I mean, it's an experience that I just wouldn't wish on anybody.
Taken everything from me, taken my job, my ability to work, took my partner off me. It's taken everything from me.
What did you need from health services that you did not receive?
I needed health services to know about this. I needed them to know what I tried telling them was real so they could help me or at least be understanding and not dismiss me.
I needed to be treated with more empathy and compassion. I was often treated as a non-compliant, difficult patient who couldn't accept the reality of her condition.
That last doctor, when I tried to talk to him about what was going on, would have been able to see through my tears and been able to differentiate the symptoms of withdrawal from relapse.
I really needed acknowledgement and validation that what I was experiencing was real. I also needed a safe place to go where I had no fear of being sectioned or drugged up to manage my symptoms.
They denied the possibility of withdrawal with such conviction that I left every appointment feeling like a crazy person. And their lack of understanding made me feel like I was the problem.
So I want to spend I guess, the rest of my lecture trying to make sense of why what you've just heard then is so different from what is in textbooks about the trouble people have coming off antidepressants. So the context for this talk is 1 in 7 people, 1 in 6 adults in Australia are on an antidepressant. It's about 3.5 million people. The average duration of use in Australia is about 4 years. Most guidelines recommend 6 to 12 months of use for an episode of anxiety or depression. Australia is now one of the highest users of antidepressants in the developed world, and 2 antidepressants are now in the top 10 most prescribed drugs out of all drugs in Australia. Women are prescribed antidepressants more than men, and older people more than younger people, and they're more likely to be prescribed in poorer inner regional areas. And people have suggested that they're being prescribed for following deprivation and inequalities. Long-standing guidance in Australia says that discontinuation symptoms are usually mild and last a week or 2. And this description is based on studies conducted by industry after people had been on antidepressants for 8 to 12 weeks. So it is true for short-term users, although even some of those users already had quite severe withdrawal effects. It's still a true statement for the short-term users. However, with people in Australia using the drugs for more than 4 years on average, there's a very big disconnect between what the guidelines say and what's happening to patients in practice. We'll see that there's a relationship between how long you've been on a drug for, including antidepressants, and how severe and long-lasting withdrawal effects are. And so to me, this is a little bit like a car company crashing a car into a wall at 5 kilometers an hour and saying it's safe on impact, and ignoring the fact that people are driving around on the road at 60 or 80 kilometers an hour. The drug manufacturers also put together this term, discontinuation symptoms, which has no scientific meaning, which has come to be used in place of withdrawal effects. And along with this description, brief and mild, became common clinical knowledge because it was so widely distributed. Along with that, the therapeutic guidelines or psychiatry college guidelines at the moment recommend stopping these drugs over about 4 weeks, halving the dose for a couple of weeks, halving them again, and then stopping them. We know that this guidance is not based on any research. It was the consensus of committees at the time. There's a single study showing that stopping antidepressants abruptly in 1 day produces severe withdrawal effects, and the committee thought that 4 weeks was a reasonable period of time. And we know that this is what most commonly happens in practice. People are told to reduce their dose to a half for a couple of weeks, often by splitting the tablet in half, then halving again, perhaps by taking half a tablet every second day and then stopping. A recent randomized controlled trial in the UK showed that that's unsuccessful for most people who have been on antidepressants for more than a year, which means that a lot of people in Australia are currently trapped on their antidepressants because of the current guidance. One of the consequences of this is that people leave mainstream healthcare and end up on peer support forums to get advice on how to come off these drugs. And these are 2 examples of websites that get between them 1 million hits a month. About 6% of the people on these websites are Australians, and the story is all very similar. I was told to come off these drugs over a few weeks. The effects were so horrendous that I ended up in hospital or back on the medication. The doctor told me there shouldn't be a problem with coming off them, so it must be my original condition, diagnosed with relapse, and told me I may need to be on this drug lifelong. But it felt different to my original condition. I had dizziness, I had brain zaps, these little electric shocks people experience in their heads, or I had panic attacks for the first time in my life. So I've lost faith in my doctor, and the advice on this website was much more helpful than my doctor had given me. And what these websites recommend is coming off very slowly at around 10% of your most recent dose per month. So for example, if you're on 100 milligrams of a drug, come off at 10 milligrams per month, and by the time you get down to 20 milligrams, go down by 2 milligrams a month. And coming down in this way has made the process a lot easier, although not a walk in the park. We've surveyed more than 1,000 people who have sought out help from these sort of websites, and they say similar things, that clinical advice had been unhelpful because the rate of reduction recommended was too quick. My clinician wasn't familiar enough with withdrawal symptoms to advise me, or they suggested that stopping antidepressants would not cause withdrawal effects. The most common tapering period was 2 or 4 weeks, and what patients wanted was access to formulations of drug that would allow them to make smaller reductions, either liquids or compounded tablets or capsules, and access to a health professional that knew how to oversee a personalized hyperbolic taper, which we'll talk about more in a bit. So it's a bit of a busy slide. I'll just go through this briefly. This is a serotonin synapse. And essentially what happens when you add in an antidepressant, it blocks the serotonin transporter, which acts as the drain for serotonin. And so you get a whole lot of serotonin building up in the synapse between two nerve cells. It's the equivalent of putting on the accelerator on the system. And because these receptors, these are receptors on the second neuron that are now getting bombarded with signal from these extra serotonin. Because of the principle of homeostasis, we like to stay in the middle. When it's too hot outside, we sweat. When it's too cold outside, we shiver. Because of this bombarding of extra signal, these receptors downregulate. There's less of them in number and sensitivity after just a few weeks of being on an antidepressant, as if the body's put the brake on. And now when you stop the antidepressant, it's washed out of the system by the liver and kidneys over a few days and weeks. And so you get the drain is now working normally, you get normal levels of serotonin. But what doesn't just snap back to how it was before the drug was there, going back to its, let's call it factory settings, is these changes to these other receptors that have taken place over months and years. And we know that after long-term antidepressant treatment, people have abnormalities in their serotonin system that can last for up to 4 years after the drugs are stopped. In other words, you now have the accelerator off, the brake is still on, and that is probably what is causing withdrawal effects. There are also other targets of these drugs, not just serotonin, there are downstream effects. But the major point is that the body and brain adapts to the drug while you take it. And when you stop the drug, it can take the brain and body a long time to recover from exposure. And during that period of time, you can have withdrawal effects. That brings up another issue, which is people will often turn up to a clinic or the emergency department and say, I stopped an antidepressant 6 months ago and I'm having headache, dizziness, panic attacks. And the doctor will say, it can't have anything to do with stopping the drug because the drug is now out of your system. But that relies on a misunderstanding of what causes withdrawal effects. It's not the time taken for the drug to leave your system, which is a few days or weeks. It's the time taken for the system to go back to how it was before the drug was there, for this brake to be taken off, or for the system to readapt to the drug not being there. And because we know that can take months and years, that's why withdrawal effects from these drugs can last for months and years. You can also see that in animal studies, where animals exposed for a few weeks to antidepressants show changes to their hormonal system and their serotonin system that last for more than a year after stopping. And that's true for all psychiatric drugs, that there's a very long period of residual effects from the drugs that can cause long-lasting withdrawal effects. I'll give you one analogy. When you go to a loud concert, your eardrums become less sensitive to sound. And when you walk into the quiet street, afterwards, your friends' voices sound muffled for a minute or two. It's actually a sound withdrawal syndrome. And the reason why it takes a minute or two for your friends' voices to sound normal is because that's how long it takes your eardrum to relax back to its normal sensitivity, even though the stimulus, the sound, dissipates in a second when you shut the door on the concert. So it's the time taken for adaptations of the brain, or the eardrum in this case, to resolve that explains how long withdrawal effects can last for, and not just how long it takes the stimulus or the drug to disappear. So Antidepressant withdrawal syndrome is a collection of physiological symptoms that occur on stopping or reducing the dose of an antidepressant. And because these drugs affect so many bodily systems, they can cause a variety of psychological or physical symptoms. And they occur, as I've just shown, because adaptations to the brain caused by the drug take time to resolve. Another misconception is that withdrawal implies addiction, but that's not relevant to antidepressants. Addiction involves compulsion and craving, and antidepressants are not strong enough at inducing euphoria to cause addiction. But all you need for withdrawal effects are adaptation to a drug, which is often called physical dependence. Unfortunately, the terms physical dependence and addiction have become conflated. But whilst addiction is not relevant to antidepressants, physical dependence certainly is. For example, I imagine that everybody in the audience is physically dependent on caffeine. If you were to have your supply cut off, you would develop withdrawal syndrome, not a particularly severe one, but one nonetheless. And I also guess that nobody in the audience is injecting caffeine or stealing from their neighbors to get more, because addiction is not an issue, but physical dependence is, as for antidepressants. And of course, the flip side of withdrawal and physical dependence is tolerance. So over time, people become tolerant to antidepressants. This is often minimized by the manufacturers. In America, they call this poop out with their colorful language. Like, if someone's raised their hands, it's probably best to save questions for the end, unless there's something you really want to ask now.
We might just save the questions for the end. So if the person has a question, could you type them into the Q&A box? Thanks.
Yeah, that's great. Thanks, Lincoln. Thanks, Leo. So there is a very long list of withdrawal effects from antidepressants, of which this is just a selection. And it's because these drugs affect every organ system. They can cause dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia. They can even cause arrhythmias in withdrawal, nightmares. There are mood symptoms, depressed mood, irritability, anxiety, panic attacks. We know that these are symptoms of withdrawal and not just a return of people's underlying condition, because in studies where people don't have mental health conditions and are given antidepressants, pain syndromes, the menopause, or even in healthy volunteers, when they stop the drugs, they also demonstrate these symptoms, these mood symptoms. There are sensory symptoms that I've talked about. People get electric shock sensations. They can get burning sensations in their skin, because, of course, the nervous system is widely affected by these drugs. There are many gut symptoms. There's a lot of serotonergic neurons in the gut. And there's an increase in suicide attempts and suicidality in the weeks after stopping an antidepressant, even in people who have not been suicidal before they started antidepressants, which we'll come back to in a couple of slides. And then something mentioned by a couple of the women in the video I showed you is akathisia. This comes from the Greek word for can't keep still, and these are the sickest people I see coming off antidepressants. Akathisia is generally more recognized as a side effect of long-term antipsychotic use, but it can occur in withdrawal from antidepressants and actually many other psychiatric drugs. It often involves people pacing, feeling a sense of terror. I've heard a patient describe it as feeling like their nervous system is on fire. And because these people get no break from these symptoms, often week after week or even longer, there's a high risk of suicide. And when such people turn up to the emergency department, they're often misdiagnosed as having a mental illness, agitated depression or mania, when clinicians are unaware that this is one of the symptoms that can be caused by coming off antidepressants and other psychiatric drugs. The other major issue is withdrawal effects being misdiagnosed as a relapse of someone's underlying condition. In the 1,000 or more patients we surveyed, this is the main reason people left clinical care. It's easy to understand why this would happen when guidelines have said for many years that withdrawal effects are brief and mild. When people turn up to clinic with severe and or long-lasting symptoms, it's easy to think this must be relapse. This doesn't match the description that I've heard about withdrawal effects. there are a few clues to distinguish withdrawal from relapse. So withdrawal effects are often quick in onset, a couple of days or a few days after reducing or stopping a drug, but they can also be delayed by several weeks, which causes real confusion for clinicians and patients, probably because there are downstream effects that take time to accumulate. There are also specific symptoms in withdrawal, so things like dizziness, electric shock sensations are clearly not a part of anxiety or depression, but actually it's psychological symptoms that are the most common symptoms of withdrawal. And so it's very useful. Sometimes patients will tell you the answer. They will tell you, I've never felt like this before, or this is much more severe than I've ever encountered previously. It's also very useful to know what symptoms they went on the medication for and what they have now. So for example, if somebody went on an antidepressant because they were depressed, they were lethargic, they were sleeping a lot after their mother died, and now a few years later they come off the drug and they are highly anxious, having panic attacks, and they can't sleep, it's much more likely that they've developed quite common symptoms of withdrawal rather than they've developed a new onset panic disorder that just coincidentally happened to appear the moment they stop the drug, although often clinicians make that sort of misdiagnosis. If you restart the antidepressants soon after withdrawal symptoms come on, often these symptoms go away pretty quickly, but if it's delayed, results can be much more unpredictable. When clinicians are unaware of the list of symptoms withdrawal can cause, often misdiagnoses like chronic fatigue syndrome, medically unexplained symptoms, or various neurological psychiatric disorders are made because the symptoms of withdrawal overlap with the diagnostic criteria for many of those conditions. How common, severe, and long-lasting are withdrawal symptoms? The answer to this really depends on how long people have been taking the drugs for. So this is a very simple study on the right-hand side that I summarized with this graph, in which people were asked, how long were you on drugs for, the antidepressant for, before you stopped them? That's the x-axis. Did you get withdrawal effects? That's the top line. And were those effects moderately severe or severe? That's the bottom line. And when people were on the drugs only for a couple of months, most people didn't have withdrawal effects. And if they did, it was mostly mild. But by the time people are on the drugs for 3 or 4 years, most people are having withdrawal effects, and half of them are saying that they're moderately severe or severe. And different studies have looked at different points along this graph, and the drug company studies that have informed guidelines for many years were done at this side of the graph, looking at short-term users for 8 to 12 weeks. I do think that there is greater recognition of withdrawal effects from antidepressants in Australia these days. I still think there's a lack of recognition about these protracted, long-lasting withdrawal effects. It makes me think a little bit of long COVID, that originally when people heard about symptoms persisting for months or even years after getting COVID, people said, how can a short-term viral infection cause long-term disability? And that was pretty quickly taken up, one, because it was so widespread, and two, because doctors were affected and they were seen as credible witnesses, which is maybe less so for people that are taking antidepressants. There is some similarities between long COVID and these protracted withdrawal syndromes, although I think I've seen both groups of patients. I think the protracted withdrawal syndromes are people that are much more severely affected. These people can have trouble with light sensitivity, with balance, with panic attacks, with concentration. People lose jobs, relationships break down, people can end up bedbound or housebound. Because there is such limited recognition by the medical community, these people are left to rely on friends and family if they understand, and that leads to an extra level of difficulty. On the right-hand side, I'm just showing some of the a study we did where we asked 1,000 people who experienced withdrawal, what symptoms did you have before you started your antidepressant that led to the prescription? And what did you have after stopping the drugs? To really get at this idea, are these their symptoms coming back? And what you can see is there's a very big difference. So for example, when starting the drugs, 3 out of 10 people were suicidal. They were clearly in a bad way. But after stopping the drugs, now 6 out of 10 people are reporting suicidality. In other words, for 30% of these people, they experienced suicidality only after stopping the drugs. And you can see that a lot of these, for all of these symptoms, there are many more people experiencing these symptoms after stopping than before starting. So that's very true for impaired concentration, although that can be an aspect of depression. It's true for electric shocks. It's true for increased sensitivity to sound. It's true for dizziness, etc. I didn't show it here, but also these symptoms after stopping are much more severe than before starting. And so this is clearly a distinct syndrome that's not just people's conditions coming back and causes people huge difficulties. So there has been a very big discrepancy, I would say, between the UK and Australia on this topic. In the UK, based on this research and others I haven't shown, there's been a big update to guidance. In 2019, the Royal College of Psychiatrists, the equivalent of RANZIP in the UK, actually went on national TV to tell the public that there is a risk of severe and long-lasting withdrawal effects from antidepressants. NICE, the body that puts out evidence-based guidance for doctors in the UK, updated its guidance to talk about severe symptoms that can last for several months. In Australia, I've shown the psychiatric guidance here, but maybe the therapeutic guidelines are more relevant to GPs. There's been minimal updates to either of these guidances. They still say that symptoms are usually transient and mild and resolve with antidepressant reinstatement. And again, that is true for people that have been on the drugs for a few weeks, but that is not the case for people who have been on the drugs for years, which is now the majority of Australians. And so these guidelines, unfortunately, are increasingly irrelevant. So if that's the problem, what's the way to avoid the effects people get coming off these drugs? And maybe I'll just spend a minute talking about why even stop antidepressants in the first place. I think there's a lot of reasons why medication may no longer be needed. The first thing to say is the number needed to treat with an antidepressant to get one response is 7. That's the very optimistic accounting of the issues, so that most people that are given an antidepressant will not experience a benefit over placebo. So for many people, these drugs are not helpful at the beginning. I've mentioned tolerance. Some people will have benefit at the beginning, and that will wear off over time because of tolerance. In primary care, the vast majority of people are prescribed antidepressants in the context of a stressor. After divorce, job loss, physical health problem, death in the family, like everybody in that video montage. And these people are not likely to have a relapse. You can't have a relapse of divorce. And so most of these people do not have severe recurrent conditions. Some of them will develop alternative coping skills, and a lot of people, probably up to half, are on antidepressants for longer than guidelines recommend. And we'll come back to the pros and cons of those guidelines in a moment. There are a lot of side effects from these drugs, often in long-term use, worse than is reported in short-term studies. So more than half of people, in some studies up to 80% of people, will experience treatment-emergent sexual side effects. You may have seen that the TGA put out a warning early this year to doctors to warn that for some people, the effects of antidepressants on their sexual function will not resolve when the drugs are stopped. And there's a question about whether these effects are permanent or just long-lasting. Emotional numbing is a very common effect of the drugs. It's the main reason people come to my clinic in London to come off the drugs. Fatigue, impaired memory, and impaired concentration have been shown in healthy volunteers given antidepressants. So these are not just this is not just depression, but this is a result of antidepressants. They also cause insomnia, and there's a small but growing literature on worsening anxiety or depression caused by long-term use of these drugs. And although weight gain was not prominent in short-term studies, it is in longer-term studies where about a third of people will develop significant weight gain. There are also physical health consequences, particularly for older people. There's an increased risk of strokes, obesity, falls, cardiovascular disease, osteoporosis, cataracts, and even premature mortality. There are particular issues for women of childbearing age, with an increase in teratogenicity of women on antidepressants by about 2 to 3-fold from quite a low base rate. And then for older people, there's issues with polypharmacy. I just want to talk about one major barrier to people stopping antidepressants, and that is the belief that antidepressants correct a chemical imbalance, a little bit like insulin corrects diabetes. So it's now broadly held by psychiatrists that depression is not caused by low serotonin or a chemical imbalance. So the Royal College of Psychiatrists in the UK said the old idea that antidepressants correct a chemical imbalance in the brain is an oversimplification. We do not support this view. They've removed reference to chemical imbalances and low serotonin in their website. The same has happened in America, and in Australia, they've also removed this sort of language from their descriptions. We published a paper on this topic a couple of years ago, looking at all the studies that have compared healthy volunteers to depressed people and found there was no difference in levels of serotonin in any way that we looked. What was surprising about this paper was, although psychiatrists said, this is old news, we already knew this, it became front page headlines in every major national paper in the UK and some in Australia. And it was because the public had been sure that antidepressants corrected a chemical imbalance that was known to be the cause of depression. In fact, this paper was shared so much that out of 23 million papers that have ever been published, it's been shared in the top 300 because it was so startling to the public. We know from surveys that 85% of the Australian public believes that depression is caused by a chemical imbalance. We know that if they believe that, they are much less likely to stop their drugs, even if they're not indicated anymore. There are other explanations for how antidepressants might work. Things about acting on the growth of new brain cells, on inflammation, on stress hormones, none of which have been shown in clinical populations. It's actually what I did my PhD in. Mostly this work derives from animals or cell studies. And there's a much more plausible explanation for how antidepressants exert their effects, which is emotional numbing. We know that most people who are on antidepressants report that their emotions are numbed. That is, that the normal range of their emotions from very positive to very negative has been restricted into the middle. And you can see why that might be a relief if you have anxiety, panic attacks, and the volume is turned from a 10 to a 3, can be a great relief. It's also the number one reason I mentioned that people come to my clinic to come off these drugs, because it doesn't just affect negative feelings, it also affects positive feelings. It affects people's relationships, their sense of self. And so I think it's worth bearing that in mind, because it's a very different thing to be told that this is a drug that will correct an underlying chemical imbalance like insulin for diabetes, versus being told that this drug will numb your emotions. Those sort of things lead to very different decisions about how long you might take such a drug for and the way that it works. So I'm going to spend 1 minute broadening what I've just said to psychiatric drugs in general, before I go back to how to stop them. There's two different ways to understand how psychiatric drugs work in general. This is antidepressants, benzodiazepines, and other drugs given for mental health conditions. There's something called the disease-centered model, which is how we understand how drugs work in general medicine, which is that drugs act on the underlying abnormality in a condition and reverse it. So blood pressure medication to relax blood vessels, to reverse high blood pressure, and insulin replaces a lack of it in diabetes. A very appropriate way of understanding things. In the mental health conditions, this sort of disease-centered model relates closely to chemical imbalances. And antidepressants, I've just said, correct an underlying chemical imbalance. But there haven't been found any underlying chemical imbalances in depression or anxiety or PTSD or OCD or really any mental health condition. There's also a lack of any specificity when it comes to psychiatric drugs. For example, stimulants, anti-anxiety drugs, and antipsychotics all have similar effects in people with depression as do antidepressant drugs. There's little evidence of any specificity in psychiatry. in physical health medicine, we don't give diabetes drugs for blood pressure, whereas in psychiatry, there is a very big mishmash of which drugs are given for which condition. And that has led people to formulate a different model for how psychiatric drugs work, and what is called the drug-centered model. In this idea that psychiatric drugs are seen to be psychoactive drugs, that is, they cross the blood-brain barrier and they affect brain function. They affect how we think, how we feel, and how we act. And in this way of thinking about them, there is no distinction between drugs that are used for psychiatric treatment and those that are used recreationally, like alcohol and cocaine, except that psychiatric drugs are often not as pleasurable to use as street drugs. For example, lithium and antipsychotics particularly thought to be unpleasant to take. But what is useful in this model is you can understand that the effect of the drug, let's say sedation and relaxation in the use of benzodiazepines, may of course be experienced as a relief for many people. However, the drug is not returning people to their normal state or their pre-symptom state. It's being superimposed on whatever is there. So for example, if you're socially anxious and you drink alcohol, you'll be less inhibited, less anxious in social situations. Nobody would say that alcohol has reversed the underlying cause of social anxiety, or that social anxiety is caused by an alcohol deficiency. Everybody understands that this has been superimposed on top. When the drug wears off, the condition will come back. It's an abnormal state. It's a disruption of normal brain function that's been superimposed on top of whatever is going on underneath. And as for recreational drugs, psychiatric drugs like antidepressants tend to cause tolerance to their effects, so that there's less and less effect over time. When the drug is stopped, as I've said before, adaptations that arose will no longer be opposed by the drug. People get withdrawal effects. And whereas a disease-centered model assumes psychiatric drugs normalize brain function, in a drug-centered model, you can understand that the drugs create an abnormal biological state. These effects may be worthwhile in certain circumstances. However, they're acting by distorting normal bodily functions rather than correcting them. And it's therefore possible to understand why drugs like antidepressants might do more harm than good, especially in the long term, when you take away this idea that they're correcting something abnormal in the brain, rather they're causing something abnormal. Let's get past that. And so just to turn to antidepressants in particular, most people in surveys report blunting on these drugs. It affects positive and negative emotions, like I mentioned. The emotional numbing is proportional to genital numbing, to sexual effects people have in studies. In fact, if you chew up many antidepressants and swish them around your mouth, they will numb your mouth. So there is an anesthetic aspect to these drugs. For a while, people argued that it was actually the depression causing emotional numbing, but there was a high-profile study a couple of years ago at Cambridge in which they gave healthy volunteers antidepressants and produced emotional numbing in just a few weeks after they were given the drugs. And it has, as I said, lots of consequences in the long term. Often when I talk about depression not being caused by low serotonin or a chemical imbalance, people ask me, well, then what does cause depression? I'm going to give a couple of quick answers to that. Number one, depression is extremely common. There was a study where they followed 1,000 people born consecutively in a hospital in Dunedin, and actually by the age of 45, they'd given diagnostic tests every few years to look for mental health conditions. And by the age of 45, I'll give you the answer here, most people met criteria for a mental health condition. So now, most of us walking around meet criteria for a condition at some point in our lives. There's been huge expansion over time of how many conditions. The threshold has been lowered, so most of us meet criteria. And most of that, I should say, is anxiety and depression. So 85% of that is depression or anxiety. So by the age of 45, 7 out of 10 of us will meet criteria for major depressive disorder or generalized anxiety disorder. So it is not an exception, it's the rule. And then I also say, my grandmother had a very good idea of what caused depression. It was when life was very difficult. And that is exactly what the best research in the field shows as well. These graphs show you the number of stressful life events someone experiences in 12 months. Divorce, job loss, moving city, death of a loved one. If you get more than 10 in 12 months, it's called a severe stress. If you have none, it's 0. And this is your risk of depression in the next 2 months after that. So people that have a lot of stress are 30-fold more likely to experience depression. In medicine, I haven't seen a relationship this strong except when it comes to smoking and lung cancer. And yes, people's personality plays a role. The more neurotic you are, which basically means how sensitive you are to stress, the more likely you are to become depressed. And there is a bit of genetics, of course, in personality. There's upbringing, but also genetics. And you can see, essentially, that when people are not stressed, almost nobody is depressed. It's very few cases. I remember being taught a lot about uncaused depression in medical school, something that was purely genetic that came out of nowhere, but it's not found in research, and I haven't seen it in my clinical practice. So I think that most research is showing us that it's the context of people's lives that are causing depression and not abnormal chemistry. You don't need an abnormal brain to be depressed. You just require a normal brain exposed to levels of stress. And then the other point before going on to how to stop the drugs is the natural recovery for depression is extremely good. Some of the internal documents from the drug companies around the times they were launching these drugs was a lot of worry that there was no space for drugs because natural recovery from depression was so good. Within 12 months, 75% plus of people will recover from depression, whether or not they're given treatment and whether or not that depression is severe or mild, and whether or not they go to primary care or secondary care. So I want to spend one moment talking about the evidence for long-term use of antidepressants. So the therapeutic guidelines or other guidelines around the world that recommend to continue antidepressants for 6 to 12 months for an episode of depression or for more than 2 years for recurrent episodes. People sometimes think that those guidelines are based on long-term studies where people on antidepressants are compared to people on placebo, and people on antidepressants do better in terms of relapse. But no such studies have ever been conducted. All there are stopping studies, what are called discontinuation studies. That is that in this sort of cartoon here, people who have remitted on antidepressants, that is people who have responded very well to them, are randomized to either stop or continue the drugs. And they are looked at for relapse for a few months or up to a year after the drugs are stopped or continued, and they're given various depression rating scales. And when you put together all of these studies, you find that about 40% of people who stopped antidepressants relapse in that period of time, and less than 20% who stay on the drugs relapse. And the difference between these two values is why guidelines recommend long-term treatment. They're saying it's about halving your risk of relapse. But these studies have been criticized. Number one, looking at people that have responded very well to antidepressants is already a very selected group of people, and these sort of studies are being extrapolated to all users. But even more importantly, in these studies, the drugs are stopped most often over 1 day, stopped abruptly, and the average time that they're stopped over is 5 days, which means that a lot of people in the group that stops are going to experience withdrawal effects. We know that involves low mood, anxiety, sleep problems, which will register on all of these depression rating scales. And so some of the people in this group who were classified as relapsing will actually have their withdrawal effects misclassified as relapse. And so the difference between these two groups is not as large as these studies suggest. And some researchers have actually estimated that the entire difference between these two groups can be explained by withdrawal effects, which means that antidepressants are not preventing relapse, but preventing withdrawal effects from antidepressants. To use a slightly glib analogy, if you took people who were smokers and randomized them to quickly stop smoking or continue smoking and measured anxiety and irritability, you would conclude that people should continue smoking to prevent the relapse of anxiety and irritability. Now, cigarettes and antidepressants are not similar drugs, but the point is, if you ignore withdrawal effects, you can come to quite perverse conclusions about the relapse prevention properties of drugs in these kind of discontinuation stopping trials. And that's just making the point that withdrawal scores, which are the DES, also look like depression and anxiety when you use these depression rating scales for different antidepressants. So the last section I want to talk about is how to safely stop these drugs based on the latest research. So this is, I'm going to go through guidance from the Royal College of Psychiatry in the UK, and it gives some broad principles. It recommends that people who've been on the drugs for more than a few weeks should take months or years to come off. They suggest going down to very small doses, less than 1 milligram before stopping for some patients, and they recommend going down in smaller and smaller size reductions, and that the rate should be adjusted to the individual's ability to tolerate the process. So some of that might sound a bit unfamiliar, and I'll just explain where it came from. So we published a paper in the Lancet Psychiatry a few years ago where we looked at neuroimaging of to see the effect of antidepressants on the brain. And this is an example of citalopram, dose on the x-axis. On the y-axis is actually its inhibition of the serotonin transporter, but you can think about it just as effect on the brain. And the main point of this graph is it's not a straight line. Doubling the dose from 20 milligrams to 40 milligrams doesn't double the effect on the brain. In fact, it doesn't have a very big difference at all. And even a tiny little dose, like 2 milligrams, which you might think of as homeopathic, actually has about half the effect of 60 milligrams. And this arises because of the law of mass action, which basically says when there's not much drug in the system, all the receptors are open for business. They're all unsaturated. And so every milligram of drug has a very large effect. As there's more and more drug in the system, more and more receptors are saturated. And so every milligram of drug has less and less effect. A bit like the game of musical chairs. It's easy to find a chair at the beginning and very hard towards the end. And this traces out a hyperbola. This is the shape, if you remember high school mathematics. And it allows us to understand what happens when people come off their drugs in the usual way recommended by doctors. So say going from 20, halving it to 10, then to 5, and then to 0. It's very easy to do for a clinician, halving the tablet, taken every second day. It's very hard for the patient. You go from 20 milligrams to 10 milligrams. It causes a change in effect on the brain. Some patients find that very unpleasant. Others can tolerate it. When you go from 10 to 5, it causes a larger change in effect. When you go from 5 to 0, it's like jumping off a cliff. It actually has about 20 times the effect of going from 20 to 15 milligrams. And when clinicians are not aware of this relationship, they can conclude that people have relapsed, they need the last few milligrams of drug, they have other conditions that have come up. And so what makes more sense is, rather than reducing antidepressants by an even amount of dose, it makes more sense to reduce by an even amount of effect on the brain. And so I've drawn 4 horizontal lines, separated at 20 percentage points between them. And what you can see is that requires going down in smaller and smaller amounts, down to very small final doses, so 0.8 milligrams in this case, so that the final reduction from that dose to 0 doesn't cause a larger change in effect on the brain as the previous steps. And because this line is called a hyperbola, this has been described as hyperbolic tapering. A simpler way of explaining it quickly to somebody is to talk about proportional reductions. So for example, halving dose every month, something like 20, 10, 5, 2.5, 1.25, 0.60, produces roughly even changes in effect on the brain. Some people find even these jumps to be too large. And so some people can only tolerate about 10% of their most recent dose per month. So intermediate lines in between these lines. If you remember, that's the rate of coming off that those peer support websites recommended, I mentioned near the beginning. I think it's no coincidence that tens of thousands of people through trial and error have worked out a pattern of coming off these drugs that exactly matches the way these drugs affect the brain that we can see based on neuroimaging. And I'll just say that everything I've just said for citalopram is true for every antidepressant on the market, that the smallest available tablet, which I put in a red line, produces a very large effect on the brain. So patients are often told, you're on a very small dose of drug, you can just stop it. And that is always false, because what they're being told is they're on the smallest available tablet or capsule of the drug, But the brain doesn't care about the size of the tablet or capsule. It only cares about the effect on receptors. And so 37.5 milligrams of venlafaxine, the smallest capsule, has 95% the effect of 300 milligrams. 20 milligrams of fluoxetine has 90% the effect of 60 milligrams. 50 milligrams of sertraline has 90% the effect of 200 milligrams. And same for all the other antidepressants. So the smallest available tablet or capsule, stopping it from that dose, or even half the dose, or even a quarter of that dose, often involves pushing people off the cliffs that you can see in these graphs. I'll skip past this. There are studies now showing that people who follow this kind of gradual hyperbolic reduction are able to stop their drugs with less withdrawal effects. So this is a study where they took almost 1,000 people who had been unable to stop antidepressants in the usual way, halving it, then halving it again. They were given compounded tablets in this study that would allow them to go through a hyperbolic taper. So they went down from, say, 20 escitalopram to 19.5 to 19, all the way down to 0.5. This was the pattern of taper, exactly a hyperbola over several months. And most of them were able to stop when they did it this slowly, in this pattern. And when they were asked, how severe were your withdrawal effects? Without this hyperbolic taper, they said mostly it was very severe. And when it came to using this hyperbolic taper, they said mostly it was 2 out of 7, so relatively mild. The Royal College of Psychiatrists recommend to individualize the rate of reduction to the individual. I'll show you some risk factors later on, but there's got to be a bit of adjustment to match what a person can tolerate. If withdrawal effects become too severe, then the reduction should be halted or the dose increased until symptoms resolve and then go at a slower pace. And the Royal College now recommends the same as these websites, coming off at 10% of their most recent dose per month. They give some examples, coming off citalopram, what I would call relatively quick for someone who maybe been on the drug for a year or two, using a liquid version of the drug at the end. And here's an example for coming off a drug that's harder to come off, like paroxetine, that can take a couple of years. There's actually even 30 more steps down here, and in my clinic, taking people off this drug over 2 or 3 years is not at all unusual because withdrawal effects can be so brutal. NICE guidance says the same thing, talks about a proportion of recent dose, 50% or 25%. It encourages using liquid preparations, and it recommends the rate is determined by the patient's symptoms, and that it can take months and sometimes longer. People often ask me, and how do you do this in practice? And I appreciate that this is a practical issue, how to implement this in practice, especially in Australia. So tablet cutters, which can halve or quarter tablets, can help start things off, but by the end, most people will need something else. In the UK, most antidepressants are available as liquids. In Australia, that's not true. So the only drug available in Australia is escitalopram, which does happen to be the most commonly used antidepressant. It comes as a bottle with a dropper, which you can see on the side, and you can use that to make very small reductions. You can even put a couple of drops in 50 mils of water to then take a proportion of that with a syringe. You can get down to very small final doses. Compounding pharmacies can make up liquids, tablets, or capsules. That does, of course, provide a financial barrier, which is not currently subsidized by government. I think it should, so that people who are started on drugs by the health system are able to stop it. But that is an issue at the moment. Some clinicians decide that they're going to try to skip doses to try to get at lower average doses. This is not a very good approach for most antidepressants, because most antidepressants have a half-life of 24 hours or less, and giving the drug every second or third day causes wildly changing levels in the blood, which can lead to severe withdrawal effects. The only exception to that is fluoxetine. But one note about fluoxetine, often in guidelines, it's called self-tapering, that you can just stop it and there's no issues with withdrawal. That's not the case. Half of people will experience withdrawal effects coming off it. They're often delayed because it takes a few weeks to leave the body. And that's why this entered the guidance, because the drug company that manufactured it was very clever. It did a study where it stopped people on fluoxetine for a week and showed that there were very few withdrawal effects. And of course, that's because it takes about 6 weeks for fluoxetine to leave the blood because it's got a long half-life. And so it's a very misleading study, but that's caused guidelines to recommend it can just be stopped abruptly. So I would be much more careful with tapering fluoxetine than guidelines recommend. There are also off-label options. So for people who can't swallow tablets, older people or children, there's guidance I've given the guidance here from the NHS, but there's similar guidance in Australia on how to, for example, crush up tablets or open up capsules to mix with water, which can then be stirred or shaken because they're a suspension often, not a solution, and using a syringe to give out doses to patients. 1 in 4 drugs are used off-label, so I use this approach in my clinic when we don't have access to licensed medications. So everything that I've talked about, we summarize in the Maudsley Deprescribing Guidelines. This is written aimed at GPs, pharmacists, other clinicians, on when to stop an antidepressant and other psychiatric drugs, how to recognize withdrawal effects, how to distinguish withdrawal from relapse, and it gives guidance on slow, moderate, and fast schedules for every antidepressant and other drug on the market, and how to tailor it to the individual, as well as which formulations of drug to use, licensed and off-label options. And at the end of the talk, there's a QR code where you can get a copy for free. Just an example of some of the things in the book, there's guidance on how to stratify risk based on how long people have been on the drugs, which antidepressant they're on, their dosage, their past experience. That allows you to estimate what rate they might start at. So they could try for very low risk patients, they could halve the dose. For very high risk patients, they might just reduce by as little as 5%. There's guidance on what this sort of looks like, doing a quicker taper, when to swap to a liquid, and slower tapers for people that have trouble going through dose by dose. And then just to say that everything I've just said about antidepressants is also true for every other psychiatric drug. For benzodiazepines, for Z-drugs, even for opioids, we're reducing by a proportion of the most recent dose so that the reductions get smaller and smaller makes sense. And that's because the same pharmacology laws that I talked about apply to other drugs like diazepam, where the curves get steeper and steeper towards the end of at lower doses. So for example, going from 1 milligram of diazepam to 0 milligrams actually causes a larger change in effect on the brain than going from 100 milligrams to 75 milligrams. And we also give guidance on how to reduce diazepam in the textbook in a quicker and then a slower version. And Gabapentinoids, pregabalin and gabapentin, are already becoming big issues in the UK. They're considering it to be like a mini opioid crisis because, of course, gabapentinoids do have opioid-like effects and also benzodiazepine-like effects. People stop breathing, and so there's a lot of accidental overdoses happening, and so these drugs are being more and more tightly controlled. And for coming off them safely, the same issues apply. Again, there's this hyperbolic pattern. Very small doses have much larger effects than people think. The smallest available tablet or capsule for these drugs has a large effect on the brain, not a small effect. And we go through ways to safely reduce them in the textbook. And in fact, because the general pharmacological themes I've talked about apply to all drugs, everything I've said also applies to coming off antipsychotics. For example, things like quetiapine, which are used so commonly in general practice for insomnia, stimulants, which are becoming, of course, very widespread in their use in Australia, although they're generally easier to stop than other psychiatric drugs. And it's actually true for any physical health meds. For people that have trouble coming off beta blockers or PPIs, the same kind of curve applies, and often going down in smaller doses can make things easier to come off those drugs. So you can scan this code to get a free copy of the textbook as an electronic book. It's done through the Royal College of General Practice, very kindly. It normally costs, I think, $80, so it's save you a bit of cash. And I'm happy to take any questions that have come up.
Thank you so much, Mark. That was really interesting. There are a couple of questions, but I get prerogative by being the facilitator, so I thought I might ask a question first. Is it a legitimate thing to potentially switch someone from one SSRI to escitalopram and then use the escitalopram liquid to taper?
Yeah, it's a good question. The answer is yes, maybe, kind of, and I'll tell you why I say that hand-waving answer. Switching comes from the world of benzodiazepines. You know, people switch from short-acting benzodiazepines to diazepam all the time, and that works reasonably well because benzodiazepines are very similar to one another as a class. SSRIs, antidepressants, are not as similar to one another as benzodiazepines are. So sometimes switching from sertraline to escitalopram or fluoxetine to escitalopram can cause issues because there are different receptor effects, and that can lead to withdrawal. So if it's from a very similar drug like citalopram, then that's no issue at all. If it's from a more dissimilar drug like mirtazapine or sometimes other SSRIs, it can cause issues. So I wouldn't say never do it, because I get it. You're thinking there's a liquid version, there's an off ramp. It might be a reason to start someone on escitalopram as your first choice. But if you did try switching it, I'd be very careful. You might switch in small amounts. You might do a kind of cross titration over a few weeks. And if things started to go wrong, you might go back to the original drug. In my clinic, and I know in the UK we're a little bit luckier because we have liquids for lots of these different drugs, I try to avoid switching because it adds kind of extra complexity to the picture with, new onset side effects, withdrawal from the old drug. So that's my maybe answer. Sorry.
That's all right, thanks. Okay, now to questions from the audience. Now, why isn't that opening up? I know the first question was there it is. A revised version of the Maudsley Psychiatric Prescribing Guidelines is due out later this year. Do you know if it reflects tonight's talk?
Right. So I'm one of the authors of the Maudsley Psychiatric Prescribing Guidelines. So there's two people who aren't noticing the difference. There's two letters difference: deprescribing or prescribing. I've talked today about the deprescribing guidelines. There's a very summarized version of what I've said in the prescribing guidelines, but it's a very large book now. The prescribing guidelines, about 1,000 pages, I think, and it's developed over time. So some of what I'm saying hasn't been incorporated into the advice on when to stop antidepressants in other sections. So the prescribing guidelines is a bit of a confusing read. So there's some of this in it, and some of it, it's a bit all over the place.
Thanks. So now another question is, should all SSRI patients try hyperbolic tapering or only those who've failed the half then cease in 4 weeks approach?
Right. So I get this.
Yeah, and then there's add-on, which maybe answer the first bit and then we'll go into part B and C. Yeah.
So look, this is a good question, and I come at this from two sides. So from the GP side, I guess I'm aware I'm kind of giving everyone in the audience a headache because it's fairly easy to halve the dose for a couple of weeks, then halve it again, then stop it, and to think about using liquids, ordering compounded medications, checking in on patients, taking a year or two. It's a lot more effort, and I sort of appreciate the pressures that GPs are under. See people short periods of time. It's not easy to get follow-up. In the UK, they've tried to solve that a bit by setting up dedicated clinics. They're trying to upskill GPs with different modules and education and help. They're trying to get pharmacists involved. So I sort of know that what I'm saying is not simple to implement, and why, therefore, you might say, well, why don't we do a sort of staged approach? We'll try the simple version first. If that doesn't work, we'll try the more complicated version so that we're not exerting a huge amount of effort for everyone. I would say that's reasonable, except some people who halve then cease in 4 weeks will not recover from that for months or years afterwards. So a lot of the people in the video that you saw had that happen to them. They were halved and then stopped. And some of them were, that you heard they lost jobs, they lost relationships, they were back in bed. And you'd say, well, but didn't they just go back on the drug? Why are they still having problems? And the answer is, although the textbooks say reinstatement always works, it doesn't always work. And I think that there is some kind of injury sustained in the brain or some sort of damage when the drugs are taken off too quickly. There hasn't been any research into what it is. But when, some people have said this idea of protracted withdrawal syndrome is a bit misleading, because if someone has months or years of symptoms, neurological, psychological, somatic, that continue after stopping the drugs, and reinstatement doesn't fix it, which often is the case, then there's something going on that maybe withdrawal is not the best word for. And some people call it a withdrawal injury, and they're thinking there's some kind of injury that's happened to the brain. So I sort of think it's a bit like saying, look, if someone comes in with a broken leg, can we just sort of try some of them with paracetamol? And only if they come back, should we give them an operation? Now, we wouldn't do that with a broken leg because we're so used to, fixing and doing an operation if the fracture is displaced. But we're so used to with antidepressants stopping them quickly, which I think is, generally, risky practice. So my answer is I would only try that sort of quick stopping in a very low risk patient. So if someone has been on the drug for a few weeks, yes, definitely, a few weeks to come off it. There's a question later on about agomelatine. Yes, it's a fairly low risk antidepressant. If someone's been on that for a few months, yes, stopping over 4 weeks makes sense. But if someone comes in and they're on venlafaxine for 3 years, a very high risk antidepressant, or they're on escitalopram for 10 years, I don't think it's responsible to stop over 4 weeks as a trial. I think that the first step should be to make a test reduction of 10% and see how they respond. If they respond okay, I think you can go a bit quicker. And if they have trouble, that's a message to keep going slowly. But I think it is very risky for some people to try stopping it quickly. I've given this talk, I said to a lot of people, when GPs there's a line in the sand. When you cross the line is, can you use a liquid? Would you consider using compounded medication? If you cross that line, you'll find out that a large proportion of your patients on antidepressants will be able to come off their drugs without major trouble. If you stay on this side of the line and try just with the splitting tablets and every second day, you'll still run into trouble. So that's the sort of challenge, because I know it is, a change in practice, and there does need to be more support, and I think there needs to be systemic changes to make it easier for GPs to do that in practice. But that if you cross that line, you will find a very big difference in how easily people can come off these drugs.
Yeah, it's interesting. I mean, you're asking patients to make multiple appointments with you, and, with the state of bulk billing in Australia, it's a big financial commitment for the patients potentially, as well as the cost of compounding medications. So the next question is, any role for switching to a particular SSRI that is easier to wean from? So what is the nicest SSRI to wean from?
Actually, I'll just say one thing about your point about, Medicare rebates and so forth. I totally agree with. I mean, I sort of agree. Well, that's the context that this is all happening in. I mean, I think to zoom out, I think it's outrageous that there are drugs on the market that are approved by the TGA for which there's no easy way to come off them. So I'm telling you exactly, liquids, multiple appointments, compounded medications. To me, it's the same as if the car regulator didn't require brakes to be on a car. These drugs are on the market. They're not easy. It's not easily available to come off the drug. So I think that, the TGA needs to demand that drug companies can show that the drugs can be stopped with existing tablets. Otherwise there needs to be changes. And to answer the question you just put to me, so look, which is the nicest antidepressant to wean from. All antidepressants have a risk of withdrawal effects. Agomelatine is supposed to have relatively minor withdrawal effects. I actually have not. Since I started doing this work, I've received 23,000 emails from patients asking for advice on how to come off their drugs, and I haven't got one from someone on agomelatine. So I think that probably is true, that it's not that difficult to stop. So you might choose that. Fluoxetine probably is slightly easier to come off than other drugs, but not, as I said, not a free ride. And I guess in Australia, because there's a liquid for escitalopram, that might be a reason to choose that over other antidepressants.
Just a comment from an anonymous attendee. So a compelling presentation. I've often felt like a quack when discussing antidepressant prescribing with the patients. It sounds like prescribing SSRIs for chronic depression may be as effective as and appropriate as prescribing opioids for chronic pain. Certainly reflect my clinical experience and food for thought. So
I'll respond. It's not a question, I'll respond.
yeah.
I couldn't agree more with Y's anonymous attendee. I think it's identical. Opioids are more effective in short-term pain than antidepressants are in depression. We know that opioids wear off over time. There's tolerance, as do antidepressants. We know that opioids can make pain worse over time. That's opioid-induced hyperalgesia. In the same way as antidepressants can make depression worse in the long term. It's called tardive dysphoria. I think we have to recognize that there are no drugs that can fix loneliness, poverty, work stress. There are drugs that can cause numbing. I'm not even sure if that's that useful. It might be for some people, especially in the short term, but certainly for long term, I don't think it's really going to change people's circumstances.
So our next question is about the non-SSRI type medication. So I might add in bupropion. You've talked a bit about agomelatine, vertioxetine, mirtazapine. Do they all have the same deprescribing issues?
So yes, everything I've said basically is true for all psychiatric drugs. And so it's true for bupropion, for vortioxetine, agomelatine. So I've just put the link to claim the textbook for free into the chat. And that includes pages on vortioxetine, agomelatine, bupropion, and all the psychiatric drugs that are licensed in Australia.
And this one's a technical one. So what do you recommend for patients who have variants such as CYP enzymes known through pharmacogenic studies? So I guess those people doing MyDNA for mental health drugs.
So, there's sort of a hope that we could individualize and work out who's going to have trouble coming off or not. There haven't been any studies so far showing that any of these different liver metabolism enzymes make a difference, although it's sort of plausible. I think the main thing is to just be guided what the patient reports. So if they have trouble coming off after a test reduction, to slow things down, rather than saying, well, according to this gene test, you should have no trouble coming off. You must not be, I think what patients are saying is the most important feedback, because we just don't have enough sophisticated knowledge to know who's going to have trouble yet coming off.
So a comment, will the slides be available later? I think you said that would be fine.
That's fine.
Yep, great, thanks. And how often do you review patients in your clinic as they taper over months? Is it case by case, or do you follow a formula protocol?
Yeah, it's a bit of a combination. I sort of know that I'm talking from the luxury of having a clinic that's dedicated to this, and I'm talking to people that are dealing with a lot more issues than I am. We basically see people more often to begin with and less often as they get the hang of things. So at the beginning, we sort of have a longer appointment with people to get them going, explain what we're going to do. I would see them beginning every month for the first few months, and then sort of kick it back to every 2 or 3 months as people get the hang of things, and they might only have questions about troubleshooting. It's not true for everyone, but most people get the hang of these things. They work out if they're given a liquid. Explain, often a pharmacist can be very helpful. I get pharmacists to help to show patients how to make up different measurements. They often get the hang of things. They often get pretty good at working out what rate suits them. And so they often take it into their own hands. But yes, there's a bit more of a burden at the beginning of the taper to explain things to them.
I just wanted to ask another question, and then we'll get on to the last question. So some of the SSRIs, such as fluoxetine and sertraline, are indicated for premenstrual dysphoric disorder in an interrupted 14 days of the last menstrual cycle kind of prescribing pattern. Do you have any issues with that?
I mean, I can't say that I've got any specific expertise in premenstrual dysphoric syndrome, except that seems like a very risky practice to me, because there's a concept called kindling, it comes from the alcohol literature, where people who cycle on and off alcohol often have worse and worse withdrawals. So the first time they become alcohol dependent, come off, they get withdrawal effects. They return to alcohol and come off again, they get even worse withdrawal, and it gets worse and worse. They think that there's some sort of sensitization occurring in the brain, and people have said that they can discern similar effects for coming off antidepressants. So the idea of going on and off makes me a little bit, I think they use fluoxetine mostly for that, which makes it a bit easier because there are residual effects. But that does sound like a slightly risky way to treat things because it involves this kind of cycling on and off again and again.
Yeah, the questions keep on coming in. So we thought that this would be a very, there'd be a lot of questions with this talk tonight. And sure enough, there is. And we're very lucky to have Mark, so take advantage of his presence. So our next question is, additional question, do you think home compounding lower doses by dissolving crushed tablets, opening capsules into water, then aliquoting with a syringe is a safe approach?
So it's a fair question to ask. I think GPs always find that a bit nerve-wracking to talk about these off-label uses of the drugs. Look, we any cough syrup in anyone's cabinet that says shake before use will be a suspension. So we use a lot of suspensions in common practice. I think the answer is it's not perfectly accurate to crush up and disperse tablets or even capsules, but for a lot of people, it's the only option they have. So I think if it's a choice between not getting off the drug because there's no available formulation and doing something off-label that has some minor inaccuracies, in my view, it's better to do the thing that is minorly inaccurate but will get you where you want to get to. The guidance for doctors on off-label use in the UK and Australia says that a doctor can recommend an off-label use of a drug when the health aims of the patient is not met by licensed formulations. And I think that applies in this area. If you shake things well, and I show patients how to shake things well, you do get pretty good mixture of the drug. There's a paper that we publish soon that shows that essentially you get 80 to 100% accuracy with these kind of techniques if you do it well. So it is one option.
I have never heard of this, but there's an app called Tapermate. Have you heard of this app?
I have heard of it. It's a pharmacist actually in the ACT, I think, who has sort of put together some of the principles in the textbook that I've shown to try to make a calculator to work out reduction schemes for patients. I think it's early on in its development. I think it is available. Yeah, you might want to check it out and see if that is useful clinically.
And then the last questions we have. So if anybody has any other burning questions, type it in now. Otherwise, we'll wind it up pretty soon. And it is, sounds like have the threshold for prescribing SSRIs set far too low, and they'd be interested in having a follow-up presentation from you, Mark, about prescribing antidepressants. What do you think?
That's I'd be happy to do that. I get asked that a lot. I think you're absolutely right, Richard. There are a lot of reasons why the threshold is incredibly low. It's sort of the way that guideline committees interpret studies, which I think is very sensible when it comes to broken bones and heart attacks, and makes much less sense for things like depression. I mean, very, very briefly, the difference between antidepressant and placebo in short-term studies is marginal. It's you've got to get a magnifying glass to see the difference between the two. There's a 2-point difference on a 52-point scale. We know the drugs will not work for the majority of people that are given them. For those that do, it'll wear off, like I've talked about. In the UK, the NICE guidelines say there are 19 equally effective and cost-effective alternatives to antidepressants for depression, ranging from various forms of therapy, exercise, mindfulness. Actually, the number one most cost-effective treatment for severe depression is problem-solving therapy. I think that goes back to the fact that people are depressed because of the circumstances in their lives, not because of the chemicals in their brain. So even before we talk about therapy or exercise, mostly it's about, I think it's very hard for GPs to be given all of these issues on their desk, but mostly it's about the issues that are happening in people's lives. There's a study that was done recently that showed if you apply wait and see, if you get someone to come back in 6 weeks after they presented with a common mental health problem like anxiety, depression, 2/3 of people will not need any treatment. So there are lots of other options, but we have, there's sort of in medical training, there's a zeal to do something, which is very useful when it comes to broken bones and heart attacks, which I don't think is always the most appropriate intuition when it comes to dealing with mental health problems. And the other thing I'd say is, I don't think anybody in Australia has been given informed consent about these drugs, about how effective they are, about the long list of adverse effects, about the alternatives, about the trouble with stopping them, depending on how long they've been on them for, and also how they work. I know that a lot of clinicians are still telling patients that antidepressants work like insulin for diabetes. I think that's we know that sets people up for long-term unnecessary treatment. So that was a brief rant to summarize a longer lecture that I'd be very happy to give.
Oh, that'd be great. Thanks, Mark. We might be in touch. Last one for the night is, some patients are so keen to get off their SSRIs, they refuse to resume them when they're having problematic withdrawal symptoms. Do you recommend any other bridging medications to manage the withdrawal aside from reinstatement?
Right. That's a really good question, Morgan. I think it's actually can be dangerous to not go back to the drugs and to come off more slowly. So if I thought that if people come off their drugs too quickly, they will get a week or two of horrible symptoms and then be fine, then I'd say go for it, white knuckle it. It's just that there is a group of patients, we don't know how large, some people suggest it might be 10 or 15% of all long-term users, who will experience months and years of these symptoms. So if I could tell who's going to have a week or two, I'd say you're in the white knuckle group, you're in the months to years, you better go back. But because I don't know who that is, I always reinstate. And I always strongly encourage patients. I show them the sort of video I've shown you to encourage them to not make that risky mistake. I don't think other medications is also very effective because the brain is screaming out for that particular drug it's missing. And if you add on another drug like a benzodiazepine or an or a quetiapine, it doesn't quite get to the source of the problem. And now they're on another drug that's also going to be difficult to come off. So you end up sort of chasing your tail, you're stealing from Peter to pay Paul. So the most effective drug to relieve withdrawal effects is the drug itself. And I do try to, I'm sort of always trying to encourage people to come off, not do too quickly, and then trying to scare them straight if they're coming off too quickly. So you're sort of this trying to balance encouraging people to come off, but not to do it too quickly. So that is an issue that I've encountered as well. I would suggest you lean towards reinstatement as much as you can.
Wow, thank you so much for tonight. And I guess it's this morning for you. What time is it in England?
11:30, just coming up to midday.
Thank you so much for spending time with us tonight in the ACT. We've all found it very beneficial and very useful, and I think everyone's going to be having a look at their practice and seeing how we can kind of help patients better in this area. The other stuff, we'll send out a certificate of attendance to all attendees, and please fill in the evaluation survey. It's been a really informative, great night. So thank you so much, Mark.
Thanks for listening. Thanks for switching on and later.
See you. Bye.